you. Thank everybody for coming, and I hope the cookies don't run out. Let me just preface this saying that this is going to be a presentation in two parts. The first part is an overview of this project that we're talking about, and the second part is going to be specifically talking about the paper that's been distributed. So I just want to give everybody an overview of what the project has been because the paper is one of many and wanted to do this. And for the students who are in my class this half term, you will see that this really follows on exactly what we were talking about today. So it's nice to be able to tie the two together. So first and foremost, always, I want to thank anybody who provides financial resources. So thank you and for the Erskine Fellowship. And I also very much want to thank my own government for funding this research. So thank you to the National Institute of Child Health and Human Development. And I also want to acknowledge, even though my name is on this, I have two co-authors through co-investigators for this entire project, Nancy Reichman and Kelly Noonan. Both have been terrific. And Afira Schwartz-Scheucher, a mouthful that I sometimes mispronounce, started off as a graduate assistant, then became a programmer, now is writing a dissertation, and she's gone from being a programmer at the beginning of the project to being a co-author later in the project. Nancy and Gail, you'll see a picture of them later. I don't know them personally, but they did a lot of the data collection. Catherine McLaurin, I'll explain who she is, and Sarah McGlanahan and Irv Garfinkel were the ones who started the whole Fragile Families data set, and I'll explain that as well. So there has been a tremendous amount of interest recently on the interactions between socioeconomic status and health. And it's based on the observation that kind of within countries, between countries, however you look at this, there's a strong correlation between socioeconomic status and health. And there's evidence that socioeconomic status affects health both within a generation and, as we just talked about today, across generations. That parent socioeconomic status affects not only their own health but their children's health. And there's also evidence that poor health in adulthood can affect your socioeconomic status. If you get a disability, you're no longer able to provide the same income for yourself and your family as you did when you were well. But there's less evidence, almost none, on the effects of child health on the family's socioeconomic status. So a lot of what we talked about earlier today was the child's health on the child's later socioeconomic status. But how does the child's health affect the parents and the siblings? And that's what this project is looking at. So it's a little different than what most people in the literature have done. So what I'm going to be doing today is I'm going to be talking about just basic facts on the associations between socioeconomic status and child health, and a few of you in the room could probably do a better job on this one than I could at this point, since you've studied it to pretty big detail. Talk about some of the potential mechanisms. I am going to be talking about this project, which specifically aimed to look at the effect of child health on family resources. I'm going to review the results overall, depending on how you look at it, we've had at least 9 papers out of this, and it might not be the end of it. We keep thinking we're done with this project, and then somebody comes up with another idea, and we try it. And so it just seems to keep going. And I am going to present the hot-off-the-printer results on our current one, which is on housing. So this is the first time we're presenting the housing paper. So let me just show you this, which is from a paper by Kay, Slobodsky, and Paxson in 2002, just looking at the effect on the horizontal axis here is family income, and on the vertical axis is health, although the higher the number, the worse your health. It's self-reported health, where 1 is excellent and 5 is poor. So the people in the corner here have high incomes and good health. And the people here have, in this corner, have low incomes and poor health. And you see that there, not only is there this relationship that the lower the income, the worse the health, but the purple line is for older children, the blue line is for younger children, and you see that the difference between the purple line and the blue line gets larger and larger the older the children are. So that not only is there a health difference, there is some health difference at birth, but it grows as the children get older. So this disparity becomes even larger as children age. So you start off with some inequality and the inequality gets worse. Okay.
Does the case paper that you're citing there adjust for IQ?
There are a number of papers that I could, but this one on the parents' IQ, no, it doesn't.
You've seen doctors and stuff.
I mean, there is a lot, there's a huge literature on this, on exactly this topic, and a lot of people have just used different data with different things. And parents' ability is one that's been done less, but yes, I mean, it's, yeah? Yes. This is the parents' report of the child's health. I think so, but I'm not sure. Again, I'm reporting on their results. This isn't.
The reason I asked is because there's a self-reported health data set for Canada where it flipped from being
Parent reported.
From 58 to 12, which is exactly your grade.
Right.
And at that point, self-reported health plummets. As soon as people start reporting for themselves, it goes down. I'm just wondering if that was happening between the 9 and 12 or 13 and 17.
Who did somebody did the National Health. I think the National Health Interview Survey does have a respondent, one respondent for the household. So I think the National Health Interview Survey, it would be the household respondent, which is most likely the mother. I'm not sure. I had never used the PSID, so I'm not sure how it is in that one. But I'm pretty sure the National Health Interview Survey is the mother's. It's the household respondent's response, which is generally the mother, but not always. Okay, so the Kay, Slobodsky, Paxson, and many other articles, they looked at many potential mechanisms by which income may foster child health. And again, we talked about this a lot today. It could be behaviors like just having a regular bedtime, seatbelt use, the regular source of care, meaning having one doctor that you go to regularly. It could be parents, some attribute of the parents. So if parents are overweight, they're more likely to have overweight children. Having healthy parents means that the parents are better able to care for you, therefore your health is going to be better, whether your parents smoke in the house. And that accounts for some of the differential between those of high income and those of low income, but it doesn't explain away the differences. And they've ruled out many explanations, including health insurance. So again, one of the papers that we talked about today in class, where they compared the United States and Canada, that gradient was almost identical between the US and Canada, despite the fact that Canada has universal health insurance and the US does not. So they just concluded that the mechanisms need to be further explored. Okay, So this is our model of looking at it the other way around. So a lot of people have just said, well, parents affect their children. And I don't disagree that parents affect their children. I might disagree with some on how much parents affect their children, but I wouldn't disagree with that. But nobody really had looked, or very few people had looked at the other side. Do children affect their parents, their families, and their siblings? So how might having a child in poor health affect the family's socioeconomic status? And that's really the question that we're asking. Well, how could this be? How could having a child in poor health affect the family? And we have thought of some mechanisms, just stress in the household, the stress, additional stress of taking care of a sick or disabled child might lower the parents' effectiveness in other aspects of their lives, greater time constraints, greater financial costs, and therefore a greater financial constraint, just the complexity of life and just juggling everything, so household management. Taste in this sense that having an adverse effect, impact, something adverse happen in your life could change your view of the future. It could make you change your actual rate of time preference, that all of a sudden it could go either way. I need to live more for tomorrow or I need to live more for today. And certainly in the US, it does have a big impact on eligibility for a number of public programs. So what we've done is we have looked at a large range of outcomes, including family structure, earnings, mostly in the form of labor force participation. We've looked at participation in public assistance. We've looked at health insurance, child care, social ties, support from the family, neighborhoods, and ultimately what I'm going to get to today is housing. So this has been it's been going on for more than 5 years, this project. It's really been a big part of my life. So there really is very little literature on the impact of child health has on families. There were 2 studies done in the early 90s. One was mine with Bob Kessner, looking at the effect of poor child health on parental divorce. And what we found is that having a child in poor health you're more likely to be divorced. And I think there's a little bit more research on this today in the US, particularly with the greater diagnosis of autism. I think that that's a high divorce group. And there were a few studies a little later than that looking at having a child in poor health on maternal employment. And there's a lot of anecdotal evidence and a lot of groups that deal with specific child health problems or disabilities. Self-help groups might be looking at this, but it's a pretty sparse literature. So let me talk about my pride and joy, the Fragile Families and Child Wellbeing data set. The way this data were compiled is that it is a sample of new births in urban areas. So they're inner city hospitals. It was 20 cities, 15 states, where by design they oversampled unmarried parents. I mean, one of the things about this data is it was designed really to look at how families were doing post-welfare reform, was one of the big reasons for the design of this data set. And one of the unique features of the data set is the fact that it has so many unmarried parents and it equally follows the mother and the father. So, which makes it pretty unique. It's very hard to find information on fathers who don't live in the household. And this one has that information. I know it's fabulous. It's a great data set. So the baseline was in 20 cities in 15 states. The states were selected for their welfare regimes to get a variation in welfare regimes. We haven't been looking at that that much. The baseline interviews were from 1998 to 2000, and then there's been follow-up interviews approximately 1 year, 3 year, 5 year, and 9 years. There has been relatively low maternal attrition. The paternal attrition has been higher than the maternal attrition. And coupled with the regular fragile families data, Nancy had a separate grant where she went back to the hospitals where the babies were born a couple of years later, 1 to 2 years later, and had people go through the medical records and code everything from the medical records about the mother and about the pregnancy and about the perinatal period when the child was still in the hospital. So, and she got through the IRB, the Internal Review Board, of 3/4 of the hospitals and didn't get through the IRB of the hospital for the other 1/4 of the hospitals. Now, getting through the IRB had nothing to do with the individuals involved. It was the I'll tell you, it's a long story. But so the 75% sample of the hospitals we think is reasonably, because we almost always hold constant the cities. So we think it's, you know, it's a reasonable sample. It's not due to the parents saying, no, you can't go back to the medical records. It was always the hospital IRB. Okay, so
There was nothing about the hospital that chose to let it through and the ones that didn't. I'm thinking about Pittsburgh. You got UPMC everywhere, and then you got.
Partly it was the timing of going to the hospital, so partly it was an administrator from Fragile Family not wanting to go beyond a certain. It was a complicated story.
Okay. But there's nothing like university-affiliated hospitals going one way and non-university.
No, and it was for the most part due just to random events. So we looked at parents' relationship status, parents' employment, receipt of public assistance. And I'll go through this again, but just kind of with all these acronyms. TANF is Temporary Assistance in Needy Families. It is the welfare program in the United States as it is today. SSI is disability through Social Security. WIC is a nutritional supplement for mothers and their, especially pregnant women and young children. Food stamps are, again, subsidies for food. Housing here is housing assistance. So it could either be the form of a voucher subsidy or it could be provision of public housing. Health insurance, parent social interaction, child care, paternal crime, material hardship, and finally what I'm going to get to later on is housing. Okay, so our hypothesis is just that having a child in poor health affects a range of family resources. Most of the effects we would assume would be unfavorable because you have greater constraints, although some might be favorable because it might certainly increases the chance that you're eligible for certain programs, so you can get certain programs. That the effect of having a child in poor health will be greater for families that are more on the margin for how to allocate their scarce resources, so that the effects are going to be worse for families that have worse constraints to begin with. Okay, so what are our challenges here? Well, there's always the methodological challenge of what causes what. So you have a child in poor health and you have a family that's experiencing stress. Is it the poor child health causing the stress? Is it the stress causing the poor child health? Or is it a third factor, let's say a live for today attitude or low coping skills that affects both? So how do we deal with that? Well, one is that by using a longitudinal data set that we're using, we know what the factors were before the child was born, and we can hold constant where they were at the beginning and then look at how it affects it going forward. So just the timing, because the child's birth is very clearly defined of when that occurs. And we know what was happening before the child was born, and then we know what happens after the child is born. So one of the things that we've really tried to do here that's different from a lot of other studies is, although we have used econometrics to get at the causality, we also have really tried to define poor child health in a way that it is an exogenous shock. So it's the kind of health, and I'll explain this in a minute, the kind of health conditions that you wouldn't expect to be related to behaviors or stressors, the kind of things that just happen randomly. And then we also do use IV models. Okay. So when looking at the survey, so the mother was surveyed at the time of the birth and the mother was surveyed 1 year later, we looked at whether the child was low birth weight, whether the child was neither walking nor crawling by age 1, and whether the mother reported that the child had a major disability by the first year. And we used these at the beginning before we had our medical records information. Okay. Well, here's Nancy and Gail on the road going to the 15 states, to the 20 hospitals, to the 20 cities, to the 75 hospitals, or 3/4 of 75 hospitals, to get the information from the medical records. So they were going through these are our data collection people. So that's who Nancy and Gail are.
And the grant paid for the data collection vehicle?
You know what? Because this is my co-investigator. Nancy had the grant. That's a good question of how they allocated those funds. Good question, and I was not involved. It's good that I don't know the answer to that question, I think. How they allocated the money, I don't know. I hear they had a great time on the road. But I don't know. But I'm very happy with the data, so that's all I can say. Okay? So what we did is then they collected this information from the medical records. Now, I've got to say that birth weight is one of the best reported measures of health among anything, and the agreement between the medical records and the parents were really close. You never get correlations like this in anything you measure, but birth weight is just a great measure. But there was a lot as well. From the medical records, gestational age, APGAR scores, which, again, some of my students, we've been through this. That's when they have a score for how healthy the baby is at 1 minute and at 5 minutes after the baby's born. And then very specific conditions that the child could have as diagnosed at birth. So it could have been a respiratory problem, a nervous system problem, a gastrointestinal problem, any of these, urinary system problem. And so Catherine McClure was hired to code these conditions according to 2 criteria: severity and the likelihood that it's caused by parents. And we tried to not be involved with her coding of this at all. We wanted to steer clear of it because we did not want to influence. It's really tempting. Well, maybe if we tweaked it a little bit, we'd get a little. We were not involved. We really weren't. So it was just a grid that looks like this with severity versus whether it's could be caused by the parents or not. And we had every condition rated 1 through 16. If there's no conditions, obviously, there's zeros. So for example, in cell number 1, microcephalus, which was small head size, Down syndrome, So we had, depending on which sample, about 2% of our sample were in that cell number 1. Severe and not behavior related. And then number 2 would be a medium severity and not related, something like cleft palate, which may have long-term impact. You know, it's not as serious. And then getting back to likely behavior related and high severity, something like fetal alcohol syndrome. Yeah?
So if you have the Down syndrome, it's not behaviorally related, but it's clearly related to age of the mother, right? And you've got a control for age of the mother, but these effects are likely to be sort of nonlinear, right? And so I wonder, how much did you do in terms of running separate models on subsamples by
Well,
mother?
when I start describing the sample is really not typical of all births in the U.S. Because it's urban and unmarried, we have very few mothers who are over 35 in our sample. So actually, I mean, generally we don't, but it's just we have a young group who generally are not, you know, so we were worried about it that at some point that the testing and selection, but given, and you'll see, about 2/3 of our births were Medicaid births, so it's not a big issue for this sample. Good question.
But medicine more on selection, some people do choose to abort and others don't. And I don't know whether there's things that might correlate to that choice that might also have problems for you later on.
So in terms of what?
That the mothers, all else equal that you can correct for, who would choose to abort might be different from the ones that would choose not to, and then the ones that choose not to show up with the kids down, and the ones that do choose to.
You mean the ones who have the testing?
No. Amnio, the conditional probability of undergoing amnio is positively loaded on socioeconomic status. Hypothesis.
Say that again? That you're more likely to have amnio if you're lower socioeconomic
No,
status?
higher.
Yes.
Increasing in socioeconomic
Yes,
status.
yes.
And then therefore abortion becomes an option.
Yes, but I'm saying this is. But
people on Medicaid tend to be more fatalistic about it.
well, it's not. I mean, generally, we're talking about young mothers on Medicaid who are not going to have the amniocentesis paid for.
They might have had an ultrasound at some point.
It is possible, but
Scan to check.
it's possible, but generally, it is. But the selection is a possibility for this group, but it's
Is it true that no state Medicaid covers amnio? I would be surprised.
for a 25-year-old mother.
Yeah,
25-year-old
I'd be
mother where it's
surprised.
indicated on the glucose scan.
I mean that's.
I mean, it's something.
Yeah, no, it's something we'll look at it. What's the chance? And we can also just look at what % of these women had ultrasounds as well.
Yeah.
I don't know. Maybe somebody does. What % of births, Medicaid births, have ultrasounds? I don't know how common it is or uncommon it is.
If the ones that have had the characteristics of the ones who were born with Downs that had ultrasound are no different than the ones that didn't have ultrasound, then you're probably not going to have any selection.
Well, it's in a number of these things. Most of the ones microcephalus you could pick up possibly. I mean, a lot of the ones in this group, which are pretty small to begin with, we don't have a huge group to be, would not necessarily be picked up on an amniocentesis. So, but you know, that's something we'll definitely look at that.
Have you worried less about the amnio and more about the prior ultrasound for the 12-week scan and check for that?
So, and we'll have to see how many got it, you know,
Yeah.
which would be the first thing to look at. I don't know what % the medical records actually got the ultrasound
Yeah, none of them got it, then it doesn't matter.
12 years ago. You know, if that was a typical thing 12 years ago. I don't.
We're usually about 25 years behind the States and everybody gets it here. So.
So, okay. Okay. Whoops. So in our single equation models, what we try to do is control for baseline level of the outcome, control for the very detailed characteristics, and one of the things that we had was we had detailed characteristics on the father as well as on the mother, something very unusual. And given that the percent of births to unmarried, I mean, and just to show you what this group is like, you'll be seeing some means in a little bit, but on top of everything else, there's a lot of multi-partner fertility here. So in some of our samples, a third of the mothers had children with another father previously, and a third of the fathers had children with another mother previously. So it's an interesting group in the fragile families.
Fundamental effects across different families.
Yeah. So, but we only have detailed information on these children, you know, on the children that were born at this time. So, but we have an N of 1 where we have one father who is in the sample twice because he has 2 different children who were born in the same hospital and both got in the sample.
The same week?
Yes. Yes.
Hey, what do I line up to join?
So we have detailed characteristics of the parents, and and we also include city or state indicators, depending on which sample it is, to look at the controls in whatever the characteristics are in the jurisdiction. Okay, when we did do a 2-stage model, we first looked at poor health as a function of some identifiers, and then whatever resource we're talking about as a function of poor health. For those of you who know, finding good identifiers, a good identifier is hard to find. So sometimes we were successful, sometimes we weren't. But the other thing that we did is we actually looked, when we did find ones at least that worked, we did look at the correlations in the error terms between the 2 different equations, and often they were uncorrelated, so we considered our main results to be our single equation results and our 2-stage results, in those cases to be our auxiliary results. So let me just go through some of the findings that we have in some of our papers. So our first paper looked at the effects on poor child health on whether or not the father was in the household 1 year later. Now, according to this, about 60% of the fathers were in the household 1 year later. Now, a number of these fathers, the 40% were not necessarily in the household ever, because that's the way this is designed. And a number of the non-married births, the parents were cohabiting. And it turns out that cohabiting is what percent of the time. It gets very complicated looking at this. But in each case, what we're doing is we're just comparing poor child health to another variable that we would expect to be related to the outcome, which here is whether the father's in the household. So the previous research looked at marriage, but we're just looking at father presence in the household. So what we found is the effect of poor child health reduced the probability that the father was in the household by 10 percentage points, which is about the same as the effect of being a non-Hispanic black, just as a comparison group. So this is a strong effect. And again, this was published in 2004. Now we're looking at maternal labor supply and comparing the effect of poor child health compared to education. So, okay. So the average mothers in the labor force at 1 year was about 50%, which, again, those are mothers who have 1-year-old children, so below what for all mothers. And the effect of poor child health was about 8 percentage points negative. So these mothers are about 8 percentage points less likely to be in the labor force, and it's almost as large as the effect of going from less than high school to high school, which is about 13 percentage points. So it's a large, this is a large, we consider this a large impact, yes?
Did you interact that with those education efforts? One is more likely to be in the workforce if the child isn't in poor infant health, if the addiction of ashes?
I'm trying, I think we did in this paper. I mean, in a number of papers that we did subsamples, not interactions, but subsamples on particular groups, and the effects generally were greater in the groups that you would expect them to be greater. So in the lower, in this case, probably in the lower SES group. Again, because it's the effect of just having these resources available. But honestly, I'm going to have to go back and look at that because it's been a few years since I've looked at that. I know we did subsamples. I don't remember what they were. Good question. Okay. Father's labor supply. So the mean, 90% of the dads are in the labor force at 1 year. And so poor infant health has an effect of about 4 percentage points in a negative direction. And it's a little less than the effect of the father being a high school graduate versus not being a high school graduate. So again, it's a pretty large impact. Okay, then this one is looking at the effect of poor infant health and whether or not the mother lived with both parents at age 15, which is kind of a proxy for her own socioeconomic status growing up. For a number of public programs, TANF is welfare, SSI is disability, Medicaid is public insurance, then housing assistance, food stamps, and WIC. So for being on welfare, the effect is about 6 percentage points, and about a quarter of these mothers overall were on welfare when the child was 1 year old. Okay. This one is not a big surprise because in order to receive disability insurance, either the mother has to be disabled or the child has to be disabled and the family has to be poor, below a certain threshold. So the child poor health is an eligibility factor, so you would definitely expect to have greater SSI participation among children who are in poor health. The Medicaid, on about a little over half of these women are on Medicaid, meaning public health insurance at 1 year, and the effect is 14 percentage points higher. But again, yeah?
So can you break out, or maybe you have broken out, to what extent if you have somebody who's in really bad health at home, you showed the previous labor supply effects, is that because it requires more hands to work in the home, or is this an income effect from these different government programs that are coming in? Or?
We did, it's a good question. We haven't been able to disentangle exactly how it's happening. I mean, I think there's some of both. There is a literature, I don't know if you guys are familiar with it, on the fact that changing the SSI rules has people substitute from welfare to SSI, and SSI is a very popular program because it pays more than welfare. So it certainly would be a work disincentive to receive SSI, but we haven't been able to disentangle how much of the effect is just due to greater time constraints and how much is due to the impact of the programs, which would just be the effect of substituting you away from work because you have greater support. And the other advantage of SSI is that SSI does not have the 5-year time constraint that welfare does. So SSI is a good deal.
Is the order of magnitude about what people have estimated with regard to some of these income effects? Right, so you got the child effect, right? I mean, you can in some sense do a back of the envelope.
We could. We haven't. We haven't, but that would be an interesting thing to do, to try to disentangle it. And that would be a really interesting thing to do. we just haven't, with all that we've done, we still haven't gotten to all of this. And this is just at 1 year, but it would definitely be interesting to follow that one forward and see what the labor market effects are later on, how long-standing they are. And the SSI is a funny thing, too, because when it seems to me idiosyncratic which people they decide are disabled enough to get SSI and which ones aren't. Yeah?
The unconditional base rates, 2 versus 6%, are very interesting. It's very hard to qualify for SSI in your sample and almost easy to qualify for Medicaid.
Right, but this gives you the ticket to get SSI, having a child in poor health.
But there's a small fraction of your sample qualifies for SSI, but a majority qualifies unconditionally for Medicaid. And 56.
Yes, because Medicaid. No, Medicaid is just poor, although the threshold is if you can also get Medicaid if you're a high spender, yeah?
So you've got data that says which disabilities are correlated with parental behavior. I'm wondering whether you see more of those showing up among the group from Medicaid to switch on to SSI. You've got some incentive. I want to get onto SSI. Maybe I'm going to smoke and drink a lot while I'm pregnant. You might not think the elasticity's there, but it's worth testing.
Well, it's sick. It's sick. It is. But we actually have looked at some. We actually do have some papers where we do look at the parent-caused ones as well.
And would you see an increase?
But we didn't look at SSI. Now, one of the big debates in SSI is drug addiction a disability to get you on SSI? And so, because we have looked at drug use during, so, but I don't know. I don't know how many women would go to those extremes to get public benefits. I think.
My midwife was saying that she had some clients from the other side of the tracks who would smoke on purpose because they wanted nice little babies. They wanted cute little babies, not these big ones. So they would smoke on fucking purpose. Now that's a pretty small effect. Getting us SSI, that's a big effect.
If you found it and get published in the AER, that's reason enough.
Do it! I want to know!
The accusation that there was moral hazard in the 20s and 30s so that men from the wrong side of the tracks could qualify for regular SSI in middle age was widespread among the Chicago cynics, among whom I learned social science.
So, well, anyway, it's an empirical question. I find it hard to believe that most people would go to those extremes, but I've heard stories of people, shooting a toe to get out of military service or whatever. So I will.
How much competing for aid?
So it's an empirical question, and okay, leave it at that. Okay. We did look at the effect of poor child health on paternal crime. Now, looking at this data set, it is a group of men who were at high risk for committing crimes. We looked at crime of whether they've been convicted or incarcerated. It's self-reported. And this is a relatively new study. It hasn't been published yet. They have a little bit of a backlog. But again, we did find an effect that, so in terms of that having a child in poor health did increase by a large magnitude the probability that the father would either resume or, for the most part, resume, but to some extent start crime as well. Okay, so additional results. Now, some of these have been published, and some of these haven't been published. Some of them will never be published because some papers that don't have results never get published. So we didn't find any effect on child care use or on household arrangements. So somebody was talking about grandparents. We didn't find anything with that. We didn't find any effect of poor child health on health insurance, and this one got a nice publication. And so we've had various papers looking at the child's health insurance, meaning Medicaid, the mother's health insurance and the father's health insurance. So it didn't seem to affect that and this is some of this later on. And this is any health insurance, not just Medicaid.
It does include Medicaid?
It does include Medicaid.
I'm to take from the second bullet point that having a child in poor health because of a congenital condition has nothing to do with the probability of the family's eligibility for Medicaid?
It does affect the child's. It can affect the income standard, depending on your expenditures. If you have large expenses for a child in poor health, you can qualify for Medicaid at a higher income than you can if you don't have extraordinary expenditures. So in that way, it does affect Medicaid. But many of our women are eligible for Medicaid whether the child has a health problem or not. The majority, yeah?
You believe the first line that point from health doesn't affect the extended family arrangements. That's what I don't believe that. I think.
Do you know what? I'm glad you said that. We have gone, we keep revisiting this issue. We've looked at it. We haven't looked at the most recent survey. It certainly didn't at 1 year. We keep thinking doubling up. We keep thinking, and you'll see when I'm going to be done with this in a minute. I have a hard time believing it, but we keep trying and we never get any results with that. Yeah?
When you say does not affect, does that mean you have coefficients that statistically significantly very close to zero? Or does it mean that you have coefficients that are not statistically significantly different from zero?
We get them insignificant and positive and negative. I mean, really, just we're not close. The magnitude, depending on the specification, jumps around.
Okay, so it's not so much it does not affect, but you don't know.
We don't know. We can't find any evidence that it does.
You don't have evidence that it doesn't affect, so to speak.
I don't know how you get that evidence if you run.
High confidence intervals around zero.
Okay, yeah.
Okay. But if you think in the data sets, you've got all these measures, a really rich data set on the parents, but is there any corresponding richness in terms of the activities and behavior of the extended family, whatever that may be?
Well, there's a lot of questions asked about the extended family and who takes care of the child and where the child is. It's very rich. And whether it's from the mother's side of the family, from the father's side, this question.
My priors are with the huge, but that's the.
One more and then I'm going to move on, yeah.
Well, I just wonder, this is an area where I'd expect the affect heterogeneity, right? So do you run it differently by race and
We have definitely done it, and particularly in this sample, and you'll see means in a little bit. We have a large Hispanic and immigrant population, which would be much more likely to double up generally than our other samples would.
and that doesn't change anything?
We can't find it. So we have a recent paper on social ties and social interactions, and then I'm going to move on. So the parents are more likely to break up, not work. Mother's more likely to rely on public assistance. Father's more likely to engage in crime. Doesn't seem to have a big impact on health insurance in our later work. And appears that public assistance makes up for some of the negative effects on the family. Okay, the effect can take longer. These were all either 1 or 3 years. Definitely need further follow-up studies, and I think that study on how the public help is making up for labor force would be very interesting. And depending on how you view this, I certainly view this as I think these are families that really need some help. Yeah?
Did you also run testing all those variables for 1 year prior as well as 1 year after?
Almost all of these studies had baseline controls for everything. For the only one that was a little harder was the maternal labor force. We had to go further back because we didn't think, are you currently working when she was in the hospital was a good question. But we had baseline controls for just about everything.
So the progress were a 10 percentage point increase.
Given where you were before, yes. So we had baseline controls for just about everything. Okay, so basically, so far what we've found is that the socioeconomic status, health interactions, that low socioeconomic status leads to fewer resources and poor health leads to fewer resources, that there's kind of a feedback mechanism that others haven't looked at, that the poor infant health can affect your socioeconomic status that could then affect your health going on because you'll have fewer resources for the child and for other children in the family. We don't have very good information on the other children in the family. So that we do find that poor child health seems to contribute to the intergenerational pattern in poverty and health. That having a child in poor health means fewer resources for the family, except to the extent that the public takes over. Okay. Kids affect their families, and it affects their parents. It doesn't all go from parents to children. It can go from children to parents and within families. Okay, part 2. So now I'm going to talk about our current study, the one that is hotter off the press here. And we have a co-author on this, Mara Curtis from Boston University. And we're looking at the effect of child health on the family's housing situation. So what are the effects of poor child health on the family's housing situation? What do we know about housing and health? Well, high correlation between poor housing conditions and poor health, and that the causal pathways have not been clearly established in the literature. Is it poor health? Is it poor health that causes you to have a worse housing situation? Is it housing that causes health? Something that a lot of people have assumed, being in poor housing causes you to have poor health. Or is it a third factor that affects both or some combination? So there have been many studies looking at specifics, and let me kind of tell you what some of these specifics are. Asbestos, lead paint, rodents, dust mites, lack of heat, mold. We know that well here, and mold. Yes. And generally, they find that these things tend to have bad effects on children. I think I'm learning to live with mold since I've been here. And there's been more on crowding, on health and educational outcomes. So crowding could operate through just more communicable diseases. The closer you are to people, the more likely you are to get something from them. Reduced ability to regulate stimuli, increased stress, and there's definitely an association between crowding and educational outcomes. So everybody, your kids need their own rooms, right? So that's what they would say, right? So tell them to go to the studies and find the economic literature supporting their contention. So on housing affordability and health, so housing affordability could affect crowding, but it could also just affect the amount of resources that you have availability to spend on health care, given that you're spending a lot or not so much on housing. Okay. Again, okay. So one of the few studies that really looked at, was kind of designed to get at some of the causality, was the Moving to Opportunity study in the US that gave housing vouchers to individuals who were living in mostly poor neighborhoods that they could only use if they moved to a neighborhood that had a lower percent poor, I forgot what the threshold was, than when they were living. So it's a threshold, and you have to move to what's considered a non-poor neighborhood. And they found that both the parents and the children who had moved, and getting the voucher was random, among people who were eligible, had better health than the control group. Okay. So there's a literature on housing instability, and the literature on housing instability has not found very convincing effects overall. Some do, some don't. The design is different. Okay, so there really haven't been a lot of studies looking at the reverse causality that poor health may affect your housing situation. There's plenty of anecdotal evidence. You'll read these articles in the American press that I spent all my money on health care so that my mother, spouse, child wouldn't die, and now I'm penniless and homeless because of the fact that I did that. So you hear those kinds of things, but you don't, there haven't been a lot of studies. Furtick and Reinhold found that poor health status and depression were associated with later homelessness and doubling up. Finney et al. Found that mental and physical health problems were positively associated with later homelessness, but not with evictions among mothers on welfare. And the MTO study found that with the people who received those vouchers, which was a random sample, people in families where the child had poor health were less likely to use the vouchers. So they had an opportunity to move up, and they didn't take advantage of this opportunity if the child had poor health. Okay. So there's related literature on health shocks, on educational outcomes, on economic outcomes. I mean, most have focused on the elderly. A few have looked at the pre-retirement age, including all of our studies. And generally, these studies find that health shocks cause financial strain, may reduce expenditures on other household items, may reduce labor supply, and can affect income, and can affect expenditures on goods. So I'm not going to go through the fragile families again, except to talk about, on top of a lot of questions that they asked from the mothers about the housing, and having geocodes so we know the information on the census tract where the mother lives. There was also an interviewer who went out to the houses to interview the families and assess the housing. So the interviewer was asked a lot of questions about the condition of the housing. So we have an independent source of the housing quality as well as the neighborhood and the mother. So we're looking at this 3-year outcome. The 3-year is the first year that the interviewers went out to a large extent to the households. So what we're looking at, that the housing outcome is a function of child health and all the other characteristics I've been talking about. And we assess the endogeneity of child health first by carefully constructing our measure of child health through this child health shock, and then performing a falsification test that I'll show you. So we have a number of outcomes on child health. We have whether the mother reports that there was inadequate utilities, which has your electricity or water been shut off or heat been shut off for more than, I think, 48 hours in the past 12 months, something like that. The interviewer observation of poor housing quality, which was, oh, here we go. The inadequate utilities is whether the family's electricity or gas had been turned off, or heating oil had not been delivered in the past 12 months, or the family had not had running water for a period of 48 hours or more. And poor home quality from the interviewer assessment is whether there were broken or cracked window panes, unconcealed or frayed wiring, mice or rats, open cracks or holes in the walls or ceiling, significant broken plaster, peeling paint, or broken stairs. So a number of very specific things. So here's our housing options. They didn't interview all the families, so this is a smaller number. This was, this was also from a specific interview that wasn't interviewed of everybody, and all the other outcomes are just from the general survey. So our sample size does vary here depending on the extent of the interview. And you'll see that about 8% had inadequate utilities. For the interviewer assessment, almost a third of them had some major problem in the household. Crowding was about 1/5. A small percent were evicted, homeless, or lived in a shelter. About 3% were homeless. We looked at mobility, moving 3 or more times in the past 3 years, and moving in with others for financial reasons, which
4% with 3 or more times in 3 years.
that's what they say. That's what they say. Okay. So so looking at our child health shock, we looked at that severe condition. We looked at severe condition or very low birth weight just to increase our sample, and it's thought that of people who had a health problem, and very low birth weight is less related to maternal behavior than low birth weight. So very low birth weight is 1,500 grams or less. And then a moderate or severe condition, so that was 1 and 2 in the grid. So it could be a less severe, but it's not mother-caused. Okay, so here's our child sample. So about 2% had a severe condition, 3%, 20%, about half were boys. 2% were multiple births, and they were about 36 months at the 3-year interview. Just looking at the mother sample, you'll see that the mother's age there's a young sample, very much more ethnic than the US population as a whole, 15% immigrants, a high percent who have less than a high school education. About 2/3 of them had the birth financed by Medicaid, which is just an indicator for poverty. We're not using it as Medicaid being negative in terms of birth outcomes. But if you're using Medicaid to finance the birth, yeah?
So presumably the causal effect when you've got some severe illness in the child and it's soaking up family resources and therefore can't be devoted to housing. Are we pretty confident that severity as coded here is related to amount of resources required to take care? Like in extreme case, my kid is unconscious in a coma. Actually, it's pretty easy care. Might get coded as being severe, but maybe wouldn't necessarily have big drains.
That's true. So but then it would be an empirical question of, are we coding it in a way that if we never get any effect on anything, but even take your example, it might not take your financial resources, but it might take your time resources.
Right.
So if you're in the hospital all the time talking to your child who's in a coma or whatever, you might not have the time to keep up your house or move to a better place or do something else. So it might not be financial resources, it could be time resources as well.
When these were coded, they weren't coded with that in mind.
They were just coded with whether or not the mother caused it and is this a severe health condition. So is this something to be more likely to be long-standing? So take something like one of our more moderate ones, which is cleft palate. It could be that it's fixed it depends. So we don't know, and that one is less obvious that that's going to be long-standing. And some of them, we obviously excluded from this sample anybody who had died by the time they were 3. And we also don't have in the sample people who are no longer living with their mothers. It's a very small sample. So if they're in an institution somewhere, we're not observing them. So they're living at home. These 2 are the mother's health from the medical records, whether the mother had a physical health condition. The most common one was a respiratory problem, asthma or some other respiratory problem. and whether the mother had a diagnosed mental illness, which could include depression, anxiety, bipolar disorder, schizophrenia, anorexia, suicidality, and mental retardation. Okay, so here's our regression results. So the two, these are quality, crowding, and stability. So basically, what we get is some significant effect that's at the 10% level. So it's not hugely significant. It's positive everywhere, of a moderate child condition on house quality. And what we get is a much more significant effect of a very poor child health on this more, I think, serious housing outcome is evicted, homeless, shelter, or whether or not you become homeless. So it seems that if the child has a problem, but it's not severe, we're getting some effects on the quality of the household, and this seems to go all the way for the family to be evicted. Yes? Or homeless.
We might get to the thing. I'm wondering about selection and homeless again, whether the homeless are less likely to get the antenatal scan. We've got a declining coefficient from severe to the less severe. Severe is including the ones that might be picked up on an antenatal scan. Homeless might be less likely to get an abortion because they'd be less likely to notice it. They wouldn't have gotten the antenatal scan.
Again, I'll go through our coding again. The majority of these I don't think would be picked up on an ultrasound, but we can definitely look at this some more. And again, this isn't the compulsive pregnant women group that you might be more familiar with. You know, I think our sample's a little different, but yeah.
So in a lot of these tables, it would be really helpful for you actually to present the covariates, right? Because if one of our worries is this stuff isn't really random, well, one quick check we could do is, are the other covariates changing when you move from your supposedly one random shock to your other supposedly random shock to your third random shock?
And I do have some sample, so there are some results in the paper. I'm not.
That include in the tables that I had. None of them, the only one that has the covariates is the one where you just look at severe health conditions.
Okay, so, okay.
So can you just tell me what happens to the covariates?
Not much. I mean, and first of all, not many of them are that significant in any of the, you know, we don't.
But does their point estimate jump around, right? That's
Yeah.
an indicator.
You know, I'm going to have to go back and look at that. Okay. So we're getting some effects here for the most severe kids on crowding and on homelessness. Generally, the less severe the condition, the smaller the effect, becoming insignificant. And getting back to your comment, what's your name again? John. That in terms of moving in with others and family things here, this is low magnitude and, you know.
So when you look at the presence of these shocks across your 20 locations, do they seem sort of nicely randomized across those locations? I'm thinking, you know, other supposedly random stuff shows geographic clusters, right? So my concern here is not, I mean, you control for a city fixed effect or whatever, but what I'm concerned for here is there's lots of unmodeled stuff in here, right? So your dependence is going to be problematic because you only have really 20 clusters, right? And you know, depending on how much dependence there is, it's going to be hard to do inference, right? So you might need to do some bootstrapping or something like that, unless you're convinced that these shocks really are sort of randomly dispersed across these.
Well, let me. So here's some full results, but one of the things that we did is that we kind of looked, you know, if the location affects both the condition and the housing, then you would expect to flunk at least a falsification test, where we're looking at the prenatal housing and the child health, and we get no effect there. So, I mean, that is one way to kind of, if you're thinking that there's a relationship that way, at least we're not getting it there. But are these conditions clustering in certain cities, and are we really getting independent results across our 20 cities or our 75 hospitals? That's your question.
Well, yeah, my question is you know, you don't really have an N of 3,000. You may well just have an N of 20, right? Depending on what kind of clustering is going on with these health shocks, right?
I mean, there are, you know, I just put up a few examples, and again, I have been somewhat hands-off with the medical just because I didn't want to second-guess our coder. But there is a long list of different types of health problems. They're not all Down syndrome. They're not all, which have been found to have geographic clusters, for example. There really is quite a range of it's a small number. We're only getting a few percent of the sample. But it is, you know, 1, 2, 1, 3, you know, in terms of the conditions. It was pretty small. I mean, we can look at that some more, but I really don't think that's what's going on, because there were just so many different conditions, and then expanding it, when we expanded it to the moderate, which is a pretty broad set of conditions, it tends to be pretty consistent, always the same sign, a little less magnitude. So, I mean, this is another way that we look at it, just a different way of looking at it. When we did it with the other way, with just the birth weight and didn't walk or crawl, we got consistent results with that one as well. So we've had pretty consistent results looking at it a number of different ways. Yeah?
Just following on John's question, I mean, just so I understand what you said. So basically, this is a standard error question, is that right? And then you're using probing. You can use cluster robust.
Everything's clustered. I mean,
So would that be addressed that way, John?
Well, so most of the stuff written in the last sort of 4 years suggests that clustering doesn't get you out of problems unless you have a sufficiently large number of clusters, right? So if here you've got 20 clusters, for some DGPs, that's just not going to solve the problem, right? Which is why you're going to want to do some kind of bootstrapping or something like that.
So anyway, generally our other coefficients would work as you would expect. I was surprised at you know, the fact that we didn't get you know, in terms of mean number of persons, affects overcrowding, poor house quality from the medical record, affects homelessness. So the things that we got were things that you would expect, but we didn't get, you know, shocking results from the other covariates. So poor child health affects housing in multiple domains. We don't know the mechanism by which this is happening. The socio-demographic characteristics work as expected. We didn't get any effect of maternal physical health on housing, although in that case we found maternal physical health, you know, that one is potentially endogenous. We got mixed effects of maternal mental health on housing. The results in the paper don't have a significant effect, but for some of our outcomes we did. And we also got the prenatal housing conditions are predictors of postnatal housing conditions. Not a big surprise. So we include city indicators. We excluded maternal health because of potential endogeneity. We did it with a uniform sample, just taking the same sample for all of our groups. We did our falsification test, just that the postnatal thing didn't have any impact on the prenatal conditions. So the summary is that child health shock increases the likelihood of overcrowding and homelessness, at least as far as we've been able to ascertain, and that broad measures of child health seem to affect housing quality. We looked at multiple domains of housing quality, and we're really the first to look at this question of whether health affects the family's housing, and particularly the child's health affects the family's housing. So there's a lot more outcomes that we could look at. We only examined one type of health shock. There's other types of health shocks. We have, you know, tried to characterize it, but it's hard to it's hard to do. And the one thing about our sample that could potentially be a problem is that we could possibly have selection bias due to selective attrition, that it's possible that people in poor health might be more likely to drop out of the sample. We could be having some kind of attrition that way. So that's a potential caveat. So we add to the sparse literature on this topic, and the extensive literature on housing and health, looking at it though from the other way, we add to the literature on social inequalities in health, that kind of where we started today, and that if we're going to have a policy implication, it would be that there should be a little more coordination for programs. If you do have a child in poor health, that some kind of housing assistance might need some kind of coordination. So thank you.